Good afternoon to all, and welcome to the OPPI's Digital Knowledge Series. I'm Asavari Sathe, Director Communications and Patients Advocacy at OPPI. The past 2 years have made sure that the world wakes up and puts healthcare on the top of their priority list. But why did it have to be the pandemic that shook all of us to the core and make us really understand that leading a healthy life is as important while trying to be wealthy? As countries across the world are emphasizing on healthcare now as a part of their development plans, it's pertinent to get to the heart of the issue. As we celebrate the World Heart Day today, we bring to you guests and speakers who have achieved the impossible in the space of heart transplants and surgeries. They will speak with you on the launch of their co-authored book, Hriday Vikar Shastra Kriyansa Itihas, translated as A History of Heart Transplants, and of course, share their anecdotal experiences. So without much ado, let me welcome our guests for today. We have with us Dr. Hemant Pathare, Director, Heart and Lung Transplant Surgery, Jaslok Hospital and Research Center. Welcome, Dr. Pathare. And we also have with us Dr. Anuradha Malshe, Dr. L.M. Singhvi Fellow, University of Cambridge, UK. Welcome, Dr. Malshe. This session is being live streamed on the OPPI YouTube channel, and I would request our viewers to kindly share their questions or comments in the comments section that you see on your screen. Dr. Malshe is also our moderator for today. So thank you, Dr. Malshe, and I hand it over to you to start this session. Thank you.
Thank you so much for the kind introduction. I will briefly talk about the book and the journey that we took. It was a pleasant journey working on the book. I would like to say that Dr. Pathare and I were working on some other project. And while working, one day, he mentioned that this year, heart transplant has completed 50 years. 50 years, great, by the first heart transplant by Dr. Christian Bernard on 3rd December 1967. That actually started a chain of thought. Initially, we decided to write an article about 50 years of heart transplant. Then what began as an article became a series of articles, and then it became a book. We chose 13th April as the release date of our book because 13th April is a very important day in the history of heart surgery, because that is the birth date of Dr. Ludwig Rehm. He performed the first heart surgery in 1896. It is more than a century old. It has been a long journey, and we have talked about all the stalwarts in cardiac surgery and also the great names who made it possible, who made surgery safe and painless. I would like to mention Dr. Hunter, pioneer, who is considered the pioneer of importance of pathology in surgery, and also Dr. Benjamin Bell, who started using opium to reduce pain. An interesting anecdote about Dr. Bell is Dr. Bell's great-grandson too was a surgeon, and the character of Sherlock Holmes is based on him. We have also talked about Dr. Ignaz Semmelweis. He introduced hand washing before examining a patient and also before surgery, which drastically brought down death rate. The situation was so bad in France, the death rate after surgery was as high as 60%. And in Germany, the administration had reached a decision that patients are better off at home rather than in hospital because the death rate was so very high. Unfortunately, Dr. Semmelweis was ridiculed by the medical fraternity and he was committed to a mental asylum. We have also talked about Dr. John Snow, who was a British physician. He is known for his knowledge of ether and chloroform. A very interesting fact is he convinced Queen Victoria to use chloroform during her 8th delivery, which gave a widespread rise to chloroform's widespread use. From the first surgery on heart by Dr. Ludwig Rain in 1896, we have come a long way. It has been a really tumultuous journey. Here, I would like to share another interesting anecdote that is about Dr. Norman Shumway, who did the first heart transplant in the US. When Dr. Shumway did a heart transplant in the 1960s, Santa Clara's coroner, Dr. John Hauser, threatened to file a criminal charge, but fortunately, the district attorney did not do so. And very soon, the California state passed a bill about brain death. Similarly, another very famous and very interesting story about Dr. Denton Cooley is that while deposing, once he was asked by the opposing attorney that you claim that you are the best cardiac surgeon, is it not being boastful? Dr. Cooley replied, I am helpless as I have sworn to speak nothing but the truth. Then we have also talked about Dr. Demichow. He is considered the originator of the word transplantology. Dr. Christian Barnard was so impressed with his work that when on a visit to Russia, he made it a point to meet Dr. Demichow. Even our Dr. P.K. Sen was very greatly influenced by Dr. Demichow's work. In this book, we have talked about Dr. Demichow, Dr. Denton Cooley, Dr. Dibaki, Dr. Lilehai, Dr. Shumway, and of course, our very own Dr. P.K. Sen, who is considered the Bhishma Pitama of cardiac surgery in India. But here I must relate one story. It is about Dr. Werner Forsman. It is my favorite story. Dr. Werner Forsman, he was a German surgeon, and he is considered the creator of cardiac catheterization. Once while working in a hospital in Germany, he put a catheter through his elbow. Then he walked 2 floors to the X-ray lab, convinced the head of the X-ray lab, and injected a dye and X-rayed himself. It clearly showed that Dr. Forsman had put the catheter in his own right ventricle. But again, unfortunately, he was chucked out of the hospital, could not get a job, and became a woodcutter till he was honored with the Nobel Prize in 1956. Then other honors followed. The book was ready and about to go for printers. Then Dr. Pathare had a difficult case. He did a heart transplant. When he sent me this picture, I thought to myself, we must have this. This is our cover page. We have included this case in the book as a prologue. In this picture here, you see Dr. Pathare in purple cap actually performing a heart transplant. This is a real life picture. I would request Dr. Pathare, would like to request Dr. Pathare to speak.
So thank you, viewers, for inviting us to give a small talk on the occasion of World Heart Day. So yes, actually we had written a series of articles for a magazine, and they were in English. And Dr. Malche came up with the idea, why not we translate them into vernacular so that, we can put them into Marathi, so we can include them into a kind of a book, which is written in simple Marathi and which a lot of people can have access to. And that's how this idea came about. But yes, I am the director of heart and lung transplants at Just Slope, and I've been involved in more than 125 heart transplants and 89 double lung transplants. In addition to that, about 24 artificial hearts and Gardner's Omni left ventricular assist devices. So the picture which Dr. Malche just shared with you was one of my patients which I had done at Just Slope. This was a patient actually which was transferred from Sion Hospital. As a director of heart transplants, we were actually involved in the first 50 heart transplants in Mumbai as well, where along with Anve Mule, we did the first 50 at Fortis Hospital in Mulund. The first heart transplant was actually done on 17th of February 1968, the first transplant in India by Dr. Prafulla Kumar Sen. And the second transplant was done on the 11th of September 1968. So we had completed more than 50 years since the first transplant in India itself. And Dr. Sen had followed up on Christian Bernard's epic transplant within the first 2 months of the December 3rd job in 1967. So coming back to this patient was actually transferred from the Sion Hospital. The cardiologist there is a friend of mine, and he had attended our lectures on heart failure. And they had desperately tried to keep this young 19-year-old alive. His blood pressure was practically not recordable, so they gave him a lot of medicines like adrenaline, noradrenaline, dopamine in industrial doses. I mean, there was no concept of micrograms per kilogram because it wasn't working. And thereafter, they put in a balloon pump, which is an artificial heart device, which kind of helps to augment the diastolic pressure, the lower pressure of the heart. Despite that, he wasn't doing very well and he crashed, so they had to put him on a ventilator. He was unconscious on a ventilator. His one lung had pneumonia, and he was having frothy red blood coming in and out of the endotracheal tube. His urine output had stopped, his creatinine had gone to 4, and he was becoming yellow. Over a period of 24 hours, he had multiple runs of very fast heart rate, which we now call as ventricular arrhythmias. So he had ventricular tachycardias and ventricular fibrillation. Now, luckily, he was in the ICU, so he got about 63 shocks in the next 24 hours just to keep him alive. And his chest was actually looking like, he had come out of the oven or something, total burn marks everywhere. We transferred this patient to Just Look Hospital under my care. And I had the difficult job of explaining to the relatives that this is the only choice that he has. And they luckily were okay with it because he would have otherwise died within the next 24 hours. So we took up this gentleman on the evening of 9th of November. And we went on to put in a temporary artificial heart in this gentleman. The day we went in, his bleeding was very much. I mean, his PT-INR was 6 times normal. He was jaundiced. His bilirubin was 6. His platelet count was about 48,000. And his total counts were about 28,000. His liver enzymes, which are normally below 50, were 18,000 and 12,000. And there is a marker of heart failure called as NT-proBNP, which normally hovers in normal people below 300. This gentleman, it was about 38,000. So we had nothing to lose. So we went in and did a biventricular assist device, which is just like an artificial heart. And gradually, we steered him onwards. So by the second day, all his medicines were off. He had started to pass some urine. By the third day, it was like the dam had opened and he was passing urine like no one's business. He was passing about 3 liters, 4 liters a day. His congestion of his lungs came down. And by the 4th day, I took his breathing tube out and he was conscious. That's when he realized he's in some other hospital. Thereafter, his creatinine, which was 4, came down to 1 by the 7th day. We tried to make him stand up because he had lost a lot of muscle mass. And by the 8th day, he was standing on his own feet. He started walking around by the 12th day. His jaundice did worsen. From yellow, he went to orange. So his bilirubin was about 16. And it came down to normal by the 31st day. And he was walking up and down the Just Look Hospital corridor, ICU corridor, with the artificial heart in tow. And by the 31st day, I realized now his liver has improved and become normal. So I sent out an emergency beacon for an emergency heart transplant to NOTO. NOTO is our national organ authority. And we got 2 or 3 calls in the next 1 week, but because the size was not matching or they were too far away, we rejected them. And then on the 43rd day, we got a call from Pune, which we grabbed. So my team went and got the heart. And then we took this gentleman back into the operating theater. That's the picture you're seeing, which was shown to you by Dr. Malshe, of me operating on that patient and taking out his artificial heart and then putting in a brand new heart. This was done about 2 years ago. As of today, this young man is hitting the gym every day. He cycles or jogs between 8 to 10 kilometers every day. He's a walking, talking advertisement for where surgery has reached today. He's absolutely fit. He had COVID in between. He came out of COVID without a problem. And he's looking forward to his new shot at life. So that's what heart transplants and artificial hearts can do. So this was a patient where they were actually filling his death certificate in Sion Hospital when they thought, let's talk to Dr. Patari. And well, it's been a great journey for this man. So just like him, we have had multiple patients who we were privileged to make a difference to their lives. But this journey has been pretty tough. So I just like to share a few videos of how I take out the heart. I mean, I won't show the actual bloody part, but what the heart looks like once it's outside the body. In India, we mostly take out the donor heart and we pack it, we triple pack it. So the first layer is ice cold saline. That's followed by another bag which has crushed ice. And the third bag is just a plain bag. And then we rush this heart from wherever we are to just look where I am the head of the department. Now, there are a couple of things here. The shorter the duration of cold ischemia, the better the heart will do. There is an upper limit of 6 hours, sometimes even 7 hours is okay if it's a younger heart, beyond which the heart will not do well. So from the time I take out the heart in the donor's hospital, it may be in Kolkata, it may be in Delhi, it may be in Thiruvananthapuram, to the time I release the cross clamp in my operation theater, it should be less than 6 hours. Many times this involves me going in chartered flights, which are very expensive for the patient. But by doing that, we avoid going, we don't have to adhere to the fixed time schedule of the regular commercial flights. Many times we have gone on commercial flights. Going is not a problem. Coming back, we have to time taking out the heart or lungs in such a way that we timed it backwards. For example, we had to get a heart from Delhi, and the flight was an Indigo flight leaving at 6 sharp from Delhi Safdarjung. So from IG rather. So we timed it backwards. We knew we'll take 15 minutes to reach the tarmac. So 4:45 was the time 5:45 was the time they had to leave the army hospital, which means they had to pack the heart by 5:35, which means the cardioplegia, which is given to arrest the heart, should be given by 5:20, which means that they have to be ready by 5 o'clock, which means the patient has to be in theater by about 4 o'clock. So that's how we can't afford to miss this flight. And of course, green corridors help us a lot. And the advantage we get is we get the first 6 seats. There are 3 seats in the front row, and 5 seats belong to my team. The 6th seat has the heart or the lungs. And we board on the tarmac. We don't have to go through the regular checks. Just go directly onto the tarmac and walk up the bridge. That's about it. So that's how we do it. Once we reach Mumbai, if it's within the afternoon hours or evening hours, we have a green corridor from the Kalina section of our domestic airport all the way to Jaslok. So we get green signals everywhere. And even from say Kalina Airport to Fortis Mulund, say at 5 in the evening would take 17 minutes. Jaslok takes about 16 minutes, even in traffic. So I think the police do a great job. I'll just share a few pictures and then you can ask questions. So one of the things, so as I said, we get the heart or lungs in ice, but I'll show you what I've been trained to do and what I have done for a few cases in India as well. I'm just sharing my screen. So this is a device that I'm trained to use. On this device, I can take out the human heart or the human lungs and keep them alive. So the 6-hour rule doesn't apply to us. The longest we have kept it is 7 hours, but you can go up to 12 hours. There are teams which have kept it even up to 12 hours. The first two donations from cadaveric hearts, I was privileged to be a part of that team, the first two in the world. That was done in 2014 in Australia, in St. Vincent's Hospital in Sydney. In India, we are not allowed to take cadaveric hearts. The hearts we take are from brain dead donors. Now, unfortunately, there is a misnomer here because all the kidney transplant surgeons call brain dead hearts at cadaveric, brain dead donors as cadaveric donors. That's wrong. A brain dead donor is a brain dead donor, and a cadaveric donor is a dead person. So this kit is very useful when you take out hearts or lungs from a dead person and get it back to life. I'll just show a few more slides. So this thing is brilliant. So that's an actual beating heart, which I've taken out from a patient, a donor, and I've kept it alive on this machine for transport. I'll show you some more pictures. This is me taking out a diseased heart. Similarly, lungs, these are lungs. So we also take out lungs, keep them alive. Lungs do much better in the transport, and they make a bleating sound. So that's the difference between a donor and a recipient heart. The outgoing heart is on your left and the incoming heart is on my right. You can make out the difference. So this is the heart on the left. I've put an artificial heart assist device, and 4 years later, I took it out and gave him a brand new heart. So let me see if I can show some slides. Yeah, so I'll show you how the donor run takes place. So I'll tell you why it's called a donor run, because you actually have to run. And you can see the squad car that we are in, and it's showing 165 kilometers per hour. And actually we touched 210. It was a V12 engine, and we touched 210 on this donor run. So the minute they put the siren on, everybody moves aside. Similarly, this is how it's in Mumbai. So I have crazy sirens. So we have 2 police squad cars in front of us, 2 behind us. And they literally whack the rickshaw guys with bamboo sticks if they don't move around. So it's a tiring job to retrieve a heart. So if I show you this, the pilot is sleeping in the cockpit. The second pilot is on the floor there. My anesthetist is sleeping here. My assistant is sleeping there. And I am trying to keep awake. So this was a 5-hour donor run, 5-hour one way. So that's the second pilot sleeping down. That's the other guy sleeping there. So the plane was on autopilot. That's why it's called auto. So that's us coming from, I think, Surat. That was Vijay Shetty, our anesthetist. So yeah, so just stop sharing. Yeah, so I think I have a few questions here, which Dr. Marshani will be happy to answer. Right, so how risky is open heart surgery? I think you're asking the wrong person. Yes, it is risky, let's be frank, it is risky, but white hairs help. And I tend to do all sick patients. So the high-risk patients are those who are above the age of 75, because their aortas are calcified, their arteries are not very good, their veins are not very good, their kidneys are very old, the liver is also 75 years old. So these are the patients who are slightly at higher risk. All diabetics are at a slightly higher risk. That being said, right now we have a mortality rate of about 1%. we have a morbidity rate of about 3%. When I say morbidity, I mean small minor strokes or, re-explorations or requiring dialysis. Um, Honestly, at present, though the risk starts from anesthesia, it is when you give anesthesia for a very sick heart, the pressure falls, and that is the time the heart may infarct or get VTAC or VFib. But our normal ejection fraction or the pumping of the heart is about 60%. So we specialize in operating patients 10 and 15%. So because we do it regularly, the risk is much, much less. How do you store these organs? So I just showed you my slides wherein I said we store them in ice or on the fancy organ care system, which I can keep a heart beating for up to 12 hours or lungs for up to 24 hours. What is the transport and logistics process for this? So basically, we are offered an organ anywhere in India, depending on how serious our recipient is. We're allowed to skip the list if our patient is really sick. And once we are allotted a blood group compatible heart, we have a choice of saying yes or no. So if the patient can afford a charter flight, we obviously would prefer to charter. So if it's under 200 kilometers, we would go by an ambulance. If it's more than 500 kilometers, obviously it has to be a chartered flight. If they have a airport which is a busy hub, then we would even take a chance on commercial flights. So we time it in that manner. We have to inform the police force, and they give us green corridors on both sides, in the donor city all over India, as well as the recipient city here. So once every 5 minutes, the donor team, which is getting the heart, every 5 minutes, they are informed the anesthetist on the recipient team. So once they land in Mumbai, we usually start going on pump for the other patient here. Once they cross the ceiling, we start cutting out the heart. And once they're in just lobe, the heart has to be in ice slush. How does a patient keep infections at bay during and post-surgery and hospital stay? So routine heart surgery, bypass surgery, valve surgery is pretty safe. You hardly get any infections because we take appropriate care and antibiotics. As far as heart transplants are concerned, it's a different ballgame because we are giving them medicines which will impair their immunity. So we have to be very careful. Kidneys are the easiest to treat, even surgically, they're the simplest to do. Liver is slightly more complicated, but the immunity is very good, so that within 1 year, you're hardly on any medicines. Hearts are much more tougher. So you're lifelong, you are taking those medicines, and those medicines not only knock out your immunity, but they accelerate the rates of atherosclerosis, the coronaries. Lungs are the most difficult to do and to salvage because the minute you start breathing air, you are taking in millions of viruses, bacteria, fungi, protozoas. So yeah, lungs are the most difficult. So though we don't give patients antibiotics for our transplant patients, except antivirals, we give them antivirals and antiprotozoals for up to a year. Otherwise, if they get infected, we treat them with routine antibiotics in slightly higher doses. And that's about it. And of course, common sense like washing your hands everywhere. Don't eat street food. That is very important for these persons. How do we keep our hearts healthy? I think honestly, it's genetic. I've seen 40-year-old patients who are gymming every day drop down dead, and I've seen 90-year-olds smoking and drinking every day, drinking a ton of ghee, nothing their normal coronaries. So actually, it's genetic. But Indians have horrible arteries because our size of our bodies is increasing, but the size of artery is still the same. So an American black would have an artery which is about 4 millimeters. An Indian will be 2.5 max. 1.5 is the norm actually. So yes, you can do yoga. Yoga helps you keep healthy, provided do it from a younger age. Walk every day. As long as you can see your feet, you're good. The minute you have to kind of strain to see your feet, you know you have to hit the gym. Don't gym as if there's no tomorrow. Go easy on yourself. Because a lot of these people who die, including Raju Srivastava who died, he decided to hit the gym after a long time. His heart couldn't take it, he died. So similarly, don't run these stupid marathons. They're not for you. They're only for trained runners. Because you suddenly run the marathon, you're great. You cross the final line and you die there. So it's not a good idea. So just routine walks, 20 minutes a day is great for you. Eat healthy. Obviously, eat less of oils. If you have to take oil, take ghee. It's much better. Red meats are not great. Fish is okay. Lots of vegetables are great. Uh, Wine is okay if you are in Europe. Wine is not a good idea here. And no smoking. If you drink 2 pegs a week, you're going to be healthier than people who don't drink. That's a fact. I'm not making that up. That's about it. Any particular diet changes? No, I just told you about that. Does any heart suit any patient? Of course not. I mean, that's a stupid question actually. But I can't keep a big heart for a small person or a small heart for a big patient. So if my recipient is 60 kilos, I can't put in a 120 kilo person's heart in it. They won't be, I mean, he'll get hypertension. Similarly, if my patient is 60 kilos, I can't give a 30 kilo patient's heart to him because the heart will just fail. So you need a heart which is customized to his body surface area, plus or minus 20% of his body surface area. So if I have a patient with pulmonary hypertension, I will necessarily put a 40% oversized hearts, but that's not the topic of this discussion. What is the process of identifying the correct organ and donor and patient? Yeah, so it's a big process. You start by registering yourself on the national organ site, and you have to do regular monthly follow-ups with your treating doctor. As and when there will be a time when your medicines will start failing you. Medicines can only go thus far and not more. That is time you have to come in for surgery. And sometimes I put patients on artificial hearts because they won't reach their surgical date otherwise. That being said and done, more than 50% of all patients in India die waiting for a heart to be put in. So that's because our cardiology colleagues refer them very late, unfortunately. So there is a time when simple heart transplant will do. Otherwise, it ends up being a messy heart and lung transplant. How young have been your patients? Yeah, so the youngest I have done is a 5-year-old, but there are specialist heart transplant surgeons, my mentor, Dr. Balakrishnan, who has done it in 3-month-old patients as well. The problem with 3-month-old is patient is not doing the surgery at all, but is getting a donor. I mean, it's tough enough for the patients to lose their loved ones, but for a 3-year-old child to tell his parents to donate his organs is a bit tough. So that's why pediatric organ transplants are very rare. How do patients fund these operations? Well, so if they have the money, they pay. If they don't have the money, we do crowdfunding. There are certain states like Gujarat, Telangana, they give 10 lakhs per patient. Our government has no money to fix potholes. They don't pay for any funds here. But Siddhivinayak Temple Trust, they give. We have these various Mandir trusts all over, and Satya Sai Baba Trust, Sri Satya Sai from Andhra, they fund a lot of people. So and there are a lot of philanthropy done. Tata Trust is very important. They have been funding a lot of patients. Hats off to them. So basically it's our Hindu temple trusts and the Tatas, all these people. We are hoping that this government will try to fund some patients partly. But otherwise, crowdfunding is also very helpful. And of course, friends, relatives, everyone. Insurance does pick up part of the bill, but the problem is most of these patients, younger patients, don't have that much insurance. So if they have the insurance should pay at least. What has been your most challenging operation? My most challenging operation would not be a heart transplant. It would be a double lung transplant. That's horrible because the lungs are stuck up to the chest wall, and we have to take them down without arresting the patient. And then we have to go on pump and remove one lung at a time, put in one lung, then remove the other lung and put in the other lung. And so lung transplants are very tough because a lot of anesthesia, a lot of suture lines, and you can't see the suture lines once you finish the surgery, because once you finish the bronchial suture line, it can't be seen. Once you finish the atrial suture line, it can't be seen. Pulmonary artery line is in front of us. So, and these patients are extremely sick, lung transplant patients, and they're very emaciated. They're underweight, most of them, because most of them are on 6 to 8 liters of oxygen before they come for surgery. What more do you think needs to be researched in heart surgery? Everything. I think we need better drugs to retard the formation of cholesterol plaques in the body. We need better drugs to prevent bleeding. So you give antiplatelet agents and they start bleeding through their piles or through their stomach ulcers or somewhere else in the body. You need more medicines. Most of our heart drugs will cause the kidneys to fail in the long run. So most of the antihypertensives will cause fall in the GFR. So your kidneys take a hit in the long run. So all that is very important. And we need better artificial hearts. Cheaper is the next one, but first we need better ones which can be implanted off the shelf. Right now they're pretty expensive. So once they become cheaper, I think more people will be able to take the benefit of these things. So right now there is more research going on in total artificial hearts. I think they're becoming more smaller and smaller. So it makes it easier. The problem is you have to be trained to implant them. Every cardiac surgeon cannot do it. So what has been the most challenging and intricate case to work on? Yeah, so as I said, these patients who come in what is known as Intermax 1 category, which is really sick patients on their deathbeds, those are really difficult because they're already on dialysis, they have already got jaundice, they are infected. So like the one I described is pretty tough. But lung transplants are much more difficult to do than any heart transplant. Take it from me. I've done both. So lungs, of course. And can you explain? I think I just did. But suffice it to say that lung transplants are really difficult. And healing of the lung, of the chest, you have to open the chest like you open the car bonnet. You open it across, split it into horizontally and open it. And healing is always a problem. And biopsies are very difficult in lungs because if the needle goes too far ahead, you get a pneumothorax. Then you need an intercostal drain and all this kind of stuff. Heart transplant biopsy is pretty simple, straightforward. Yeah, I think that should answer most of your questions. Over to the
Thank you so much. Thank you so much. Before we wind up, can I request you to tell us the story when you actually asked President Obama to wait when you, and then you, because you were blinking in the heart and you landed?
Yeah, so actually, there's a lot of stories there. So, right. So I was in Australia getting trained about a couple of years ago. Obama was the president of America. And I was leading the team to get a heart from Canberra. Canberra is the capital of Australia. We were in a 4-seater plane. The Canberra run is about 28 minutes. You take off from Sydney and 28 minutes, you have landed at Canberra, which is about 360 kilometers away. So we were landing in, and it's a 4-seater, it's a single pilot plane. And there is no door there for a single-seater plane between the cockpit and the passenger cabins. So we have a jump seat. We used to go and sit there. So there was a lot of commotion going on. So I asked the pilot what's going on. So why are you speeding up? Normally we don't speed up so much. He said, he showed me a blue speck, a big blue speck in the sky. He says that's Air Force One carrying President Obama, and the Australian ATC has asked him to slow down and wait till we land. Actually, they were scheduled to land earlier, but the ATC in Australia told them to hold on. And then the Air Force pilot of Air Force One told us, go ahead, mate, it's your turn first. So we landed before he did. And that's the importance Australians give to life. I think here we see people dying in accidents, people don't give a second thought. That's sad. So the Australians give a lot of emphasis on life. So we landed, and once we land in Australia, they don't slow down. They, at the same speed, they take you to the hangar. And when we were deplaning with all our suitcases and machines into the ambulance which is waiting by, the huge Air Force One landed. So yeah, that's one of a very pleasant memory.
Thank you. Thank you. When we released the book, we had a great honor because it was released by the governor of Maharashtra, by Bhagat Singh Koshari ji. Can we have the book release? Yeah. Thank you. Thank you.
So thank you, Dr. Pathare and Dr. Malshe. Thank you to both our speakers for sharing their invaluable experiences and taking us through such an interesting journey. Lots of anecdotal examples shared by Dr. Pathare. Thank you so much. Very interesting to learn about, especially the last one that you spoke on, where in Australia, the ATC had to stop President Obama from landing before you guys. So a very interesting setup there. And I hope that our audience has also been able to enjoy this session as much. Once again, thank you to the speakers and our audience. And with this, we now conclude the session. We don't have any further questions coming in. So wishing everyone a good day and a healthy heart. This is Asavari Sathe. Thank you for joining in.